what are taboos related to health and how do they impact health outcomes?
I think it's when it comes to those topics that maybe we feel are not going to be as socially acceptable.
Welcome to Health in Hyperdrive, the podcast where we explore the breakthroughs shaping the future of healthcare. I'm Dominic James, and today I'm joined by Lauren Redfern, medical anthropologist and founder of hormonally.org.
And we always say that common doesn't necessarily mean normal. So it may be common for you to experience heavy bleeding, but that doesn't mean that it's normal.
What's the link between something being taboo and me not getting the treatment or the care that I need or should have?
It may be that a provider coming into that context is misinterpreting the information that they're being given, and then the appropriate care is not being provided.
How does that translate into being a tech founder?
I think we're able to utilize technology and these platforms to really think about what is it that people are understanding their health to mean, to look like, to be impacted by.
Lauren, welcome to Health in Hyperdrive.
Hi, Dom. That was incredibly wonderful, impressive. Thank you so much.
Yeah, well, and maybe I should say we're not in the studio today. We're recording this in Barcelona and taking the opportunity to use this facility here. Very exciting.
It's Health in Hyperdrive on tour. It's very exciting.
It is the first time. Maybe we can start this conversation talking about what are taboos related to health and how do they impact health outcomes?
Yeah, absolutely. So I guess when we think about the topic of taboo, a good place to start is thinking about how we categorize the world sort of, I guess, generally into these sort of binaries, right, of normal, abnormal, healthy, unhealthy. And the taboo topic, I think, fits into that in relation to the topics that maybe we feel culturally are a little bit unsavory, or the things that we don't necessarily want to engage in because they feel somehow, that they cross those parameters of cultural norms. And I think that comes up a lot in health, and definitely in the work that I do in women's health, when we're thinking about those different areas in the body that may be more private or related to function that we have sort of culturally, guarded in parameters around, around things that we have sort of inside outside. This idea of the taboo topic is something that maybe isn't as accessible in our cultural landscape to discuss or talk about.
And then what would be some examples of taboos? I guess there's like mental health and, there's a lot around kind of women's health, menstruation, menopause, but then I guess obesity and things like that. These are the sort of the topics that people are kind of embarrassed to talk about. Is that it? Or
yeah, I love the way that you actually your mind went to mental health first, because I think that's a super interesting example of a topic in which we've done a lot of work to undo and tackle that taboo. And I think it's funny because I often no longer think about mental health as a particularly a particularly taboo topic, but you're absolutely right. I think it's when it comes to those topics that maybe we feel are not going to be as socially acceptable to talk about. And so much of that is shaped by the landscape of what we're sort of insidiously seeing embraced in the cultural rhetoric when we're talking about health. So I think you're absolutely right that, we have my mind immediately goes to the more kind of private, intimate areas of health, things like vulvovaginal health, periods, menstruation, different areas. You mentioned perimenopause and menopause, and these sort of topics which have for a long time been shrouded in secrecy. But then equally, exactly as you say, things like mental health, obesity, or where the body feels somehow out of control. I think that's where we see that crossover into the taboo piece as well. Yeah.
And then how do these impact your health or how you get treated, or how does what's the link between something being taboo and me not getting the treatment or the care that I need or should have?
Well, I think so often we don't necessarily think about the impact. When we think about medicine and we think about the kind of navigation of medical spaces, I think because medicine itself or scientific research is considered this quite rigorous process in which there is an impact by social, and I'm going to come on to why it is impacted by the social and cultural, but we kind of tend to think of it as this empirical base of knowledge where we don't have those factors impacting this specific area. But in fact, it's an area of social cultural interaction like any other. And when it comes to, as human beings, as we grow up and we learn and become familiar with social cultural scripts of what's appropriate and not appropriate to talk about, so much of that is shaped by perception in the collective environments that we're in. So if you think about when you're at school and you're spending time with other young people, you start to pick up on these cues. Oh, that's appropriate or not appropriate to talk about. And so much of that is shaped by education. And we carry that with us, and we carry that through into the way that we interact with our health. So when it comes to the talking about those health topics, those learned social cultural behaviors really impact how accessible it is for somebody to feel comfortable having that discussion. Because if your experience was, I talked about periods when I was 13 or 14 among a group of guys, and it was a big laughing conversation, that may give you that intense experience of, I don't really want to have that conversation. And that can obviously have a very long knock-on impact when it comes to your health-seeking behaviors.
And so I'm just kind of trying to think about this a little bit and kind of with like in practical terms. So a taboo topic, say it's periods, for example, like that would impact my health because, well, maybe not me, but that would impact my health because there could be something wrong, but I don't want to talk to a physician about it. It could be that I don't know if what I'm feeling is normal or not. It could be that when I speak to a doctor, they associate it with something else and they normalize something that's maybe not normal. Is that kind of how it kind of shows up?
Yeah, I mean, I love this as an example because I think when we look at periods or menstruation, we have this shared social cultural script. And I think this happens in every area of our lives. We think we're reading from the same script, and often we're reading from entirely different scripts, polar opposite ideas that are playing out in real time. And we think somebody is understanding something from the same perspective that we are. And it turns out that the information that they hold or how they're navigating that conversation is informed by a very different experience. And when it comes to periods, if we think about the normalization of certain aspects to do with menstruation, we see this a lot of, it's sort of perceived or considered to be, normal to be in pain when you're struggling with symptoms of heavy bleeding or general menstruation symptoms. And if you're around that rhetoric of picking that up, I think you can internalize the idea that this thing I'm experiencing is normal, therefore I don't need to seek help or support for it. And we always say that common doesn't necessarily mean normal. So it may be common for you to experience heavy bleeding, but that doesn't mean that it's normal. And I think we definitely see this with particularly young women. I think it's like 90% of young women feel impacted by problems with their period, but being able to seek support from that, it can be a twofold experience. It may be shame and stigma associated with seeking support, but equally when they do seek support, if they don't have the language to necessarily express or advocate for themselves to say, I know that this is abnormal, it may be that a provider coming into that context is misinterpreting the information that they're being given, and then the appropriate care is not being provided. So it's that piece of, I think we often think that people are speaking on the same page about a matter, but actually they're coming from two very different perspectives. And that cultural idea about, well, that's just a period, that's what you have to experience and live with as a person that menstruates, is actually something that's so ingrained in our culture, and we don't even really question it or think about it. And we're making steps,
And I think that's really interesting because, we think of medicine being a scientific discipline, and it is. There's also human discipline. It's about kind of human communication. It's about what we choose to investigate, to research, and what we don't. And they're like choices that kind of people make. I just kind of reflect a little bit. I've probably got a few kind of personal, in fact, lots of personal anecdotes in this sort of space when, I think about certainly maybe women I know who are going through menopause at the moment. A lot of it is really a surprise to them, which seems quite an odd thing because it's a well-known subject and topic. But also some of the symptoms are common maybe amongst women, but not recognized by the clinicians that they speak to about these symptoms. So they're not getting the treatment. It's not really recognized. And so it's having a real kind of impact on their lives. I guess also, with talking about some of the kind of the women's health things, but, I think about also mental health and, people in my life that maybe have like dementia, and that has massive stigma. And certainly for an older generation, they don't want to maybe admit that there's something wrong with them. So then they don't acknowledge that, and then they don't go on to kind of get treatment, which ultimately has kind of a negative effect. Are you seeing those kinds of things as well?
Yeah, I mean, I love the example as well. This is so my area of research for my PhD was focused on women's experiences of perimenopause and menopause, and navigating care and treatment in the UK. And what's really interesting, you bring up the context of mental health, and so many of the stories I collected, it was quite a similar journey in which a conversation, usually the first contact with a provider, they would be triaged or put down the pathway for mental health support, because often I think we have a cultural perception of what perimenopause and menopause looks like. We can, it's mostly a woman with a fan, and we think about those vasomotor symptoms and that being the hallmark of menopause. But for a lot of women, it's like what we would call invisible symptoms, sort of this increase in anxiety, discomfort, or a real change in, just not feeling like yourself. And I think it's a really complicated, I think that we've done a lot of awareness raising to look at how there needs to be increased awareness and understanding, particularly among clinicians. But if you are a busy provider and a GP, and a patient comes to you with a list of symptoms, and one of those symptoms is, actually, I'm experiencing really quite severe changes to my mood to the point where it borders on suicidal ideation, which can happen, when you're experiencing these perimenopause is characterized by these, I think we often think of it as dropping hormone levels, but it's often these kind of erratic spikes and dips. And that can change, or cause quite intense mood changes. That GP has also been geared through the cultural landscape in which all of the focus is on mental health to think, mental health, and we go down that pathway. So it's very challenging, I think, when you're looking at these systemic whole body issues and you have a myriad of different symptoms and you're treating that, to look at kind of chicken or egg, where do I start with this? And then when we think about how it becomes part of the social cultural conversation, only through that raising awareness do we then see this is sort of the area in which we may be going down that pathway first versus the SSRI pathway. Yeah.
You started, Lauren, talking a little bit about your PhD research, and your background's really interesting. You're the only medical anthropologist I know.
So
I think it might be helpful maybe if you could explain a little bit of what is a medical anthropologist, and also now you're a founder at Hormonally. And so, maybe how does that translate into being a tech founder?
Yes.
So maybe start with the medical anthropologist. What is that?
Sure. So anthropology, if we're not familiar, is sort of study of human behavior, study of culture, study of different social systems. And medical anthropology is basically that in the context of medical spaces or medical environments or clinical environments. So quite literally that we're looking at the kind of social cultural dimensions that play out in those medical contexts. And I think that can feel quite unfamiliar because we, as I sort of said, we think about this sort of scientific arenas as these empirical spaces where social cultural ideas don't really, never the two shall meet. And actually, when you start exploring these systems, you can see that they're absolutely, dripping with social cultural rhetoric that impacts not just the way that we deliver treatments and the way that we support patients, but also the entire ways that the systems are built and the dynamics within them. So even, clinical hierarchies, how clinicians exist within those spaces, which I find very interesting. And it's obviously, been the thing that sort of inspired me moving forward with Hormonally. It was based out of, working with and speaking to countless women through their journey of seeking perimenopause, menopause support, and just hearing these same stories come up and up over and over again, which was the symptoms were a big part of that story, that so much of it was geared towards this lack of information, lack of education, and this feeling of just being completely at sea when it came to understanding what was happening in, to their own bodies, and sort of feeling like it was a Pandora's box that got lifted and suddenly all this information comes out and, weren't prepared, weren't informed, didn't know what was about to happen, and just really felt adrift in that without sort of a lifeline to hold on to. And one of the bigger pieces that we saw was, if we're looking at perimenopause and menopause as one part of the life course, really the conversations I was having, it just became so apparent that there was such a lack of, accessible education through the life course. So So really what inspired me to set up Hormonally, we're a nonprofit focused on access to evidence-based information on reproductive and hormonal health through the life course. So we have over 40 evidence-based resources on the website, and it spans everything from first period to post-menopause. And really the aim is to try and provide that education that maybe you didn't have. And, you mentioned in the introduction sort of storytelling, and we try and take that social cultural piece and recognize the importance of that when we're delivering that information and education to people, to feel like they're empowered and maybe not moving away from wanting to engage with their bodies, but actively engaging with that, because we recognize that so much of the relationship that we build with our health, with our well-being, is also about whether or not the communication lands. So I could be telling you all of these things and it's not going in, right? So we have to figure out different ways that we can deliver that education in a way where the person not only feels informed, but also, I guess, energized to put that into action.
And so I've had a look at the Hormonally website, and in fact, that's how we kind of got to know each other. You sent it through to me. I sent it to the women in my life, and overwhelmingly, the feedback that I received was like, wow, this is really interesting and very refreshing, but it's bold. So when you go onto the Hormonally website, the first thing that you see is it's vulva, not vagina, and you have a vulva map. Can you explain a little bit, like, I'm comfortable talking about this now, but can you explain a little bit of like, why is that important and how does that fit into this conversation around kind of changing the narrative and removing taboos?
Yeah, I love that example. The Vulva Map is something that we're very proud of. So if you haven't yet looked at the Vulva Map, go to hormonally.org and check out the Vulva Map. So one of the areas of health that I think we recognize is still sort of a big area in red tape is vulvovaginal health. Our vulvovaginal health is affected by hormonal changes. Women in perimenopause, menopause will experience symptoms, vulvovaginal symptoms that can cause really, really a debilitating impact to their lives. But this is through different areas of our lives. We may be experiencing vulvovaginal symptoms. And there is this taboo around seeking support. And I think what we've realized is there's twofold in that. There's taboo about seeking support, but there's also just a lack of information and education about our own anatomy. I connected with some clinicians based out of George Washington University at a conference, and one of them was speaking and sort of, I didn't know this, but a number of anatomical textbooks are inaccurately labeled. So even the teaching materials that clinicians are being provided with are not accurately labeled. So when they're learning about anatomy, they're not even getting the right information. And this is impacting patient outcomes because it's leading to misdiagnosis of particular conditions. And equally, when speaking with these providers, one of the things that they were saying is visual aids are really important when we're talking and learning with patients, particularly when English is a second language, where there is this sort of, I guess, experience of shame or taboo. Being able to have a visual prompt to refer to as you're talking about it, trying to break down those barriers and walls are really important. So we worked with them to develop sort of what we feel is a hopefully not particularly overwhelming diagram to work with, that people can access and interact with to learn more about their own anatomy. Because as we know, part of the reason we have it's vulva, not vagina, is because the shorthand that we hear all the time is people talking about their vulva as their vagina. And even though I think a lot of people say, well, what does it really matter? If we're not even using the right language to describe our anatomy, that can have a big impact when we're thinking about how we treat symptoms, how we navigate conversations about our body. So we're all about kind of trying to break those taboos, challenge those taboos, but do it kindly and do it in a way that feels approachable and like a space that you want to learn about those things as well.
Could you give like maybe an example of how like the wrong language could lead to misdiagnosis?
Yeah, of course. So in the context of this specific example, there's a condition called vestibular dynia, which is it's characterized by, it's often misdiagnosed as vulvodynia, which is sort of a chronic pain condition that it can affect everything. It can affect sexual function and being able to navigate an intimate relationship. But vestibular dynia is hormonally mediated, meaning the way that you would treat it would be through a hormonal intervention. And that's important because if you're looking at treating a particular condition, but the different words are being used to describe where you're experiencing the pain. If you're saying, well, I'm experiencing the pain in my vagina, and a clinician hears that and you're meaning my vulva, they can take that very differently. So if from a clinician's perspective, if someone's saying, I'm experiencing pain in my vagina, they would think that's internal pain. And that's very different to external pain.
It's really fascinating, right?
So, and obviously the clinician isn't necessarily going to say, I just want to stop you and check, do you mean vagina? Because how patronizing would that be, right? But if we've learned, colloquially in the language, that's my vagina. I love that this podcast, by the way, it probably will have had the most vulvas and vaginas in
yeah, maybe we can count.
Yeah.
And that, I think what's really interesting about that as well, it's also a little bit hidden, right? If I said I've got a pain in my arm, but I actually meant my leg, I'd be pointing to it. And I think we'd get the clinician hopefully would get the point.
Yeah.
But if I'm talking about, if I'm talking about kind of parts that are hidden, that it's a little bit harder because it's a little bit kind of more vague, isn't it?
Yeah, absolutely. I love actually that you made this point at the beginning in the introduction in terms of the areas of health that we feel comfortable or uncomfortable talking about.
Yeah.
And I really, I think these distinctions about inside versus outside, or like the ways that we divide the body, are really important to consider, because you think about it's the same with things like dermatological issues. If you think about skin conditions or these different areas where there's a certain level of shame associated with it, where that skin condition is no different to, anything else, but it may be that people feel this internalized idea that this isn't something that I necessarily should have, therefore I don't seek support for it. Yeah.
Yeah, it's kind of it's really complicated like that as well, because the issues are really broad. I'm kind of interested in what it means to be a founder at Hormonally. You've created a digital asset and a digital platform. Is that the focus, or you do other things as well?
Yeah, so we have hormonally.org is a digital platform that is an education hub with resources, but we're a non-profit. So we focus, hormonally.org is considered like one of our programs of support, but we do other programs as well. So a big piece of the focus that we have is how do we make education accessible? So as part of our Vulva Map program, we do clitoral crafting with people, where we go into communities and we decorate 3D printed clitorises, and we deliver anatomical education and provide spaces for people to come together and build community and talk in that way. I've delivered a workshop on roller skates, teaching hormonal health through movement. So we try and think about how do we take this education into communities and start those conversations, because a big part of it in the taboo piece that you're talking about is we're kind of constantly expecting. And a big part of our work is about providing people with the self-advocacy skills to speak up, but we're sort of expecting people to come to the clinician versus the other way around. So that's kind of how we like to look at this, is like, how do we bring this education that may feel a bit overwhelming to communities in the hope that they then want to engage with their health and well-being, and take charge of that and take ownership of that.
I'm curious about this, that these are kind of somewhat awkward topics.
Yeah.
That's the whole reason it's a taboo, right?
Yeah.
How do people respond to, say, workshops or, I don't know, painting a clitoris or whatever?
I love that. Ultimately, we have this voracious appetite for more information. And after the first 5 or 10 minutes, when you can get past that little awkward conversation, and I think, I lost all sense of, and I make a fool of myself in every context. So I think if I can lead with that openness, or when we're facilitating that openness, it opens up opportunities for people to feel safe in doing that too. And really, once the ball gets rolling, it doesn't want to stop. People often, when we come to the end of a session, they want to keep the conversation going. They definitely want to, because I think a big part of it is the education piece. But the bigger part is being in a context and environment with other women, with other people experiencing the same things, and suddenly feeling like this big weight has been lifted, and there's actually, not something wrong with you, or it's not abnormal, and lots of other people are going through that. Because I feel like as human beings, we're geared towards wanting community, but also wanting to feel seen and like we're part of a collective experience. And I think we can see that in any community building space. The thing that people are looking for is that sense of connection. How do you recognize my experience, and vice versa? So The education is a huge part of what we do, but I think the bigger part is that community building and providing environments for people to come together and talk about their bodies in a way that feels stigma and shame-free.
I've seen that in other areas. Like I have family members who have dementia, and I've seen them, kind of start to overcome it a lot by joining kind of dementia groups, or carers joining carer groups. So this point around bringing visibility to a topic that is somewhat stigmatized, normalizing it, connecting people, it's a really important and powerful and impactful thing. Maybe that kind of brings me on to like, how does technology play a role here? Hormonally is obviously a digital platform, and actually maybe I'll take a slight tangent. Your PhD research was in testosterone, right? It wasn't in women's health, right?
Well, yeah.
Or yes and no. That's the misnomer already, right?
Yes and no. Originally, the original research I wanted to do was a multi-sited ethnography. Yeah. So ethnography is a form of research in anthropology where it's basically sort of immersive research. So it's going into a space and a place and observing in all of the contexts. So if you go into a clinic and you're doing an ethnography of that clinic, you're not just spending time observing the clinicians, you're also in the reception area, you're in the admin office, you're really seeing every different area to kind of grasp that whole picture and function. Originally, I wanted to do a multi-sited ethnography of testosterone use in different contexts and places in the UK. So, and that was really focused on thinking about how is testosterone perceived in these different environments by different groups. So, for example, how do bodybuilders make sense of testosterone versus men in andropause making sense of testosterone versus what ended up being my research, because apparently it was too ambitious to do multi-sited pieces. So I ended up looking at testosterone use among perimenopausal and menopausal women and thinking about how are these women making sense of using this hormone that is so traditionally associated with men, with masculinity, with these concepts of maleness, and yet they're using it for perimenopause, menopause. And I was really interested in the cultural work that went into making testosterone, for all intents and purposes, feminine, which there was work that went into it.
Is testosterone helpful for menopause?
Yeah. So, well, this is an interesting topic. I feel like I know
you're not like you don't have a medical background, but just kind of in layman's speak, because the reason I'm asking, I'm really surprised because in my head, testosterone is a male thing.
Yeah.
And so that language, like I could imagine that if you're treating women with testosterone, they're probably thinking that they're all suddenly going to grow beards and, it's going to have a lot of negative impacts on them.
Yeah, so testosterone is an androgenic hormone, but the analogy I always like to use is like if you think about a plane and a car, both of those vehicles will use fuel to run, not necessarily the same amount of fuel, but they both require it. And I always kind of say, it's the thing that we know, size isn't everything. Yeah. So the amount of testosterone that we need in our bodies may differ, but you and I, it's an essential hormone to both you and I. You will just produce greater amounts of testosterone.
Right.
Usually what you would see in a perimenopausal, menopausal patient is that a clinician would begin treatment with a combined estrogen, progesterone. And what I was observing in the particular clinic that I was doing this research was that testosterone may be added to that treatment pathway if you were not seeing the results that would be expected from just that estrogen and progesterone combination. The interesting piece about this is there's a lot of, I feel like in this, let's just imagine I am Switzerland. I take no opinion either way. What I do listen to are the narratives of women. There's a lot of colloquial evidence. I really kind of hate that we call it colloquial evidence because I collected a number of stories from women that were noticing these huge benefits and effects of using testosterone, but we currently don't have strong clinical trial data to show that. What we do know is that testosterone use among perimenopausal and menopausal women would be used for something that is called hypoactive sexual desire disorder. So if you have low libido or are struggling to feel sexually charged in the same way, you would ordinarily be prescribed testosterone. But sorry, go ahead.
Yeah, so that's, regardless a little bit of the clinical evidence, maybe as the example of something that people perceive as a very male thing, but could potentially be good for a woman.
Yes.
Maybe they wouldn't want to take it because that's actually, we also associate testosterone with kind of weightlifting and, you know, as you mentioned, and it's kind of maybe somewhat abused.
Yeah.
So it could be something that's beneficial, but because of the language around it, it's not something that perhaps people would be accepting in their kind of health and diagnosis and treatment. So that whole kind of, I guess that's kind of the nuts and bolts of what we're talking about.
Yeah. And I mean, so there's two pieces to this, which, I mean, I could talk for hours about the kind of social cultural history of testosterone, but I think the thing that often gets missed is when we're looking at where in time our knowledge about a particular piece of the body or clinical idea, that is very specifically fixed at a point in time where that research was taking place. So when it comes to, we think about endocrinology generally as a whole, as a discipline, you're looking at sort of when testosterone or the original investigations into sex hormones were happening, it was sort of at this height of modernity. There's all these conversations. And actually what's super interesting when you start researching and looking at what was happening, you have this, you know, we all know the space race, but I always like to think about the hormone race. So there was this real push for understanding what the benefits of these, I call them like endocrine actors, could be. And the rhetoric that you see in popular culture around testosterone is this bigger, faster, stronger, big association with maleness. One of my favorite little analogies is there were two researchers in the US that were trying to distill testosterone, and they ordered over a ton's worth of bull's testicles to grind them down. And they did get a teeny tiny amount. But actually what we found is that when they finally were able to, it was researchers in Europe that were able to derive testosterone, I think it was from cholesterol. So you were seeing this kind of this fascination of, no, it has to be in the balls. That's where it is versus, you know, that we're fixing it in the body as opposed to, you know, we know that hormones are chemical messengers and they're moving around our body in different amounts. But when we think about the shorthand of hormonal, when I say to you, you know, in the same way when I say testosterone, this immediate image comes up and I say hormonal.
Yeah, I'm thinking probably kind of mood swings, negative, definitely negative connotations around kind of people being a bit kind of moody and peaky and
And you think about now with all of what we're seeing around GLP-1s, or these incredible gains and leaps forward, I really genuinely believe the future of health will be hormonal, because we're just seeing this absolute, but those are all hormones. And I think one of the things that we connect it to this particular type of a sex hormone that's associated with menstrual cycles, that associated with changing moods, and that cultural perception gets fixed in our heads, so that when we have that association between what does hormone and hormonal mean to you, you know, our tagline at Hormonally is redefining what it means to be hormonal, because these are incredible, you know, messengers that are impacting all areas of our health. But so much of what we're maybe even looking at is impacted by those biases or those cultural assumptions.
I think like the thing that's kind of in my mind, this is very kind of layered and it has quite broad impact. So the type of, it's about how I talk about my kind of health. We started talking about that. It's how I describe what I'm feeling to my physician. It's also listening back the treatment that they give. They maybe recommend how I would react to that. It's how you gave the bull testicle example. It's the science associated with some of this. And then I guess there's also like the investment, like what do people kind of focus on? What are people researching? It's all of these different things, and it's all connected to culture and language, and especially impactful in taboo topics.
Yeah, and I think we're seeing that, and definitely not to wade into politics, because I won't do that, but I think we're seeing that definitely play out in everything that we're seeing, you know, huge cuts to what's considered to be DEI initiatives in the US. We know from a public health perspective that all of these different factors, your sex, your race, your class, everything, your sexuality, it will impact your health outcomes. And we currently now are in a state or situation where programs that are exploring those complex interrelated connections with health are being defunded, because we consider it to be a diversity. Women's health is now being categorized as a DEI subject, which means money is actively being pulled away from those spaces and places where we can learn more about the complex relationships between our society, our culture, and how that impacts our health. So I think it's also that piece that you mentioned about what research takes precedent. It's so shaped by the social cultural landscape. So we may think of, chemotherapy as the dominant treatment for cancer or cancers. But before that, there were multiple different trials happening, to look at treatment for this particular condition. And it just so happened that that particular treatment gets invested in, but we have no idea what happened to those other treatments that sort of went into, I think it's Bruno Latour talks about the black box, where all of these sort of possibilities that could have been to. Yeah.
That's a really interesting example, the DEI one. I mean, regardless of your politics, what's really clear is that the culture around a particular topic and the narrative around it has really tangible outcomes on investment in health and research. Yeah, that's really interesting.
Yeah.
I think maybe, I think we've outlined, the problem kind of really well, or the topic really well. I'd like to maybe change course a little bit and think about like what's the role that technology can play here or does play here? Like, what have you seen? I mean, of course, Hormonally is a digital platform. So you've built a digital platform that leverages obviously technology to address some of these issues and break some of the taboos.
Yeah.
What else have you seen, or what else is kind of going on at the moment?
Yeah. Part of the reason we wanted to focus on digital specifically was my PhD research was taking place at a very interesting time, which was the research happened in the year before the pandemic, and then the pandemic happened. And I think what we saw at that point, and I don't know, maybe people have been discussing this, but I don't know if we've spoken as much as we should about how that C chord shift in the way that we communicate has, I think, impacted health conversations forever. Because what my observation was, particularly in that community and environment, it offered this, people weren't leaving their houses, and suddenly there was this influx and need for community. And we saw, particularly in social media platforms, so much information exploding. And that was wonderful because it provided spaces for people to come together, to form community, to build friendships, to understand more about their condition. But it also led to a mass influx in misinformation as well. So you kind of had the two sides of the coins that were happening around this. But I think what I definitely noticed is the conversations about our health are no longer happening in the doctor's office. They are taking place so much further back from that moment that you reach that interaction, because it's not just the late night Google, it's also what you're seeing on social media platforms, in mainstream media, in these digital spaces and ecosystems that are feeding our understandings of our health, our bodies, our well-being, and that then informs the care that we seek. And I think what we found with Hormonally is we wanted to build a space that was safe, evidence-based information and education that met that need for information, but also combated what we were seeing, which was a massive rise and influx of misinformation at the same time. I genuinely am quite an optimist anyway, but I think the digital harnesses and holds the potential for huge progressive leaps forward when it comes to health equity. Because if you think about it, there's never been a time where more people had more access. And I think often what I hear is this very negative response to that, this like, everybody's an expert, everybody has this. Definitely in the clinical space, I think there's a lot of frustration about maybe the expert patient, the patient that's done their research, that has utilized AI tools. And I understand that changes the dynamic in the ways that interactions may be happening, but it also shows that this crosses multiple marginalizations, that people now have access to a wealth of information that they wouldn't have had previously, and also in a way that it can be broken down in an accessible manner where we can finally start to understand our bodies and our health in a way that maybe we would not have been able to before.
Yeah, there's definitely that shift. Like the thing with medicine is there's always been a kind of a power dynamic, right?
Yeah.
You're the uninformed patient, and then you go and see a super expert person, the doctor. They
Yeah.
tell you what the facts are. You walk away with, and that's what you know, and you believe them, and you trust them, and maybe rightly so, because they're qualified and they've studied and they're experts in this. But you also, I think what technology is giving us is some tools for us to help to understand some of these topics in more detail. So if I think about like the chat GPTs or the LLMs, these AI models, I can go onto these models and I can ask, my leg is hurting, what could that be? And I could get a bunch of information. The challenge there, of course, is that accurate or not? I could end up being kind of misinformed.
Yes.
And I think that's probably a little bit the negative context associated with it. But the fact that, one thing, the fact that I'm starting to engage and I have access to technology, if I dig a bit deeper, I can actually find well-sourced information.
Yeah.
It can be a little bit harder. But also there are tools being used that have the guardrails in place, where they're actually basing the information on trusted sources. And what they're able to do is almost translate that information into a language that I can understand and I can comprehend and mean something to me, so that I can have an informed decision. So it kind of changes that dynamic a lot. And I guess when we think about things like wearables, that you're kind of a little bit in the preventative space there. And there are things that I can do. Healthcare doesn't start when I have something really bad that's happened to me and I go and see a physician. It should be happening a lot further before that, right? Yeah. I mean, it should be much more kind of preventative. I should be living in a way that kind of avoids as much as possible me having to go and seek treatment for something that's gone badly wrong. Are you seeing that as well?
Yeah, I mean, there are a few things to pick up in what you said that I just thought was so interesting. Firstly, we definitely see that frustration from, earlier this year, we launched our self-advocacy toolkit, and we had a very positive response to that. But we also had conversations with physicians where they were saying, it's great that you're equipping patients with the ability to advocate for themselves, but often we don't find that there are both sides of this. So there is the patient that will fall out of the system completely because they feel so dismissed and so unheard by a provider, but then you also have the expert patient. And usually the research and the frustration can come from, I have patients that are coming in, they've done their research on AI, and they're pulling on research studies or papers that actually are not even related to human specimen, that it will be like a trial on 6 mice in 1992. And I think that piece that you mentioned about the close-ended AI systems, where we are seeing this, definitely in the US, more different institutions that are forming their own close-ended AI systems to provide that education and information. And I think we sort of have this, it's the same with any leaps forward in technology. I think we're very resistant to change. There's a sort of, I don't want that. But actually, if you think about the capacity that could have to free up the time of a clinician that has all of that information on hand to be able to provide. So it's not just information about your body, but it could be, how does that help me to, distill this into a very easy and accessible care plan that I can forward to a patient afterwards to say, these are the things that we went through, these are the steps, this is what you need to do next. And it feels like that continued model of care that I think is important to think about that. You mentioned the wearables piece. I love this conversation because I genuinely think that wearables offer, I don't have a wearable. I feel like I should go to some sort of anonymous meeting like, hi, I'm Lauren and I don't wear a wearable. Yes.
A podcast is it's not anonymous.
Yeah, it's very true. I personally myself don't use a wearable, but the people I know who have them, they get quite obsessive about this kind of this monitoring the health piece and really seeing that data in real time. The piece that I would say here that I think is important for us to address is from a health equity perspective. I think what we do see is, on the one hand, you could say that it's accessible because it gives people access to a form of monitoring that they wouldn't have had before, but it is still guardrailed in the sense that not everybody is able to afford to monitor their health in that way. So we sort of have this siloing of the longevity group versus the kind of people that are just, day to day trying to get through life and maybe can't actively engage in their health. So I would love, my dream would be to see, is there a, most wearables, you're looking at least a few $100s. I think the Whoop band is a subscription of a couple of hundred, like $150 a month, or maybe it's more than that, and that isn't actually accessible for people. So what's the lower cost option that would make this, even to just give you that blueprint picture of these are the things I need to be thinking about or working on, and get that reminder.
Yeah. I think with, just kind of building on that a little bit, I think with digital, you get a lot of, the power of digital is it can be low cost and have a mass impact. So if I think about what you're doing with the information that you have on Hormonally, there are, effectively anyone around the world with access to the internet can access that information.
Yeah.
And so in a lot of places and circumstances, people won't have access to any information, or they won't have access to a specialist.
Yeah.
They might not have access to a doctor. There's doctor shortages, and in lower income countries, that's even more kind of extreme. The fact now that there's that kind of information that's available to essentially anyone with an internet connection in the world, and there are a lot of people with internet connections in the world, that does kind of enable much more kind of equity and health. And I think if you extrapolate that, for example, with some of the conversational AI tools, again, they don't require a wearable. They just require access to the access to the internet, right? And so there are kind of, I feel like for sure at one end, you've got the people who have the all singing, all dancing attachments and diagnostics and the whole system around them. And yeah, I think that's always going to be quite expensive, and for, only a certain group. But I think there's also the trickle down benefit that's going to have an impact on a really mass scale.
Huge,
and I think maybe that's probably where the bigger impact's going to be, because it's the people who are more in need, that are more underserved, and then suddenly there's a lift for them.
Yeah, and I love that you highlight that, because I think it also offers an opportunity for a diversification in voice as well, probably for the first time, where we are actively giving access to technological advancement with a level of diversity that maybe we haven't ever seen before, if we were to harness that appropriately, right? That you're calling upon data sets or communities that are globally underserved, and being able to provide spaces and opportunities for those voices to be platformed in a different way, and for those experiences to be captured in a different way. And I mean, this brings us right back to the start of the conversation, which is this: you and I can be having a conversation, and that it can be coming from two totally different places, and we can think that we mean the same thing and we mean totally different things. And I think that is so essential to consider in health. Using the vulva vagina example, to come back to that, I might be having this conversation about a vagina and really meaning my vulva, and you think it's vulva, and all of those pieces. I think we're able to utilize technology and these platforms to really think about what is it that people are understanding their health to mean, to look like, to be impacted by. And I'm, again, the optimist in me sees that as a huge benefit. It destabilizes hierarchical systems, and I think that's uncomfortable for people. And I think our sort of response to that is often to lean into, this is dangerous and this can totally undo the systems that we have. But I think we also know that the systems we have aren't working. And maybe that's the positive lean in, is actually, rather than sort of fighting against this and pushing, how do we harness and utilize this technology, the systemic, wide, globalized change that can offer great health benefits and outcomes.
Yeah. I totally agree with that. It's like, how do you make it a force for good? And there, I mean, let's not beat around the bush. There are like plenty of negatives. Like you look at social media misinformation. There's, there's biases in data that can actually accentuate the current problems and current challenges. There's certainly like the hallucinations in like some of the models. There's data, like there's an overwhelming amount of data that isn't that useful from a lot of wearables that doctors can't make any sense of, and it actually causes more of a problem than actually being kind of helpful. So there are, on the one hand, there are like some potential kind of negatives with this.
Yeah.
That doesn't negate the fact that technology can be a massive force for good if it happens in the right way. And maybe that's a good point to sort of talk about the future a little bit. Like, what would the right way be? Like, what could the future look like, maybe from your perspective?
Look, and I think we can, there are so many issues with AI that we can see, even just the environmental drain that we can see. This is huge. I think there's a real risk to people's ability to think critically, that often it's a reach for this tool before actually engaging what feels or what we think. But for me, in terms of, I do like to lean into exactly as you're talking about, what are the optimistic opportunities within this in a health context? And I think particularly in environments, the environment that I work in women's health, there is still this huge divide in which we often, I don't think it's acknowledged, but not readily enough, that, women's health is sort of a shorthand for white middle. When we say women, really what we mean is white middle class women, but how do we bridge that gap in terms of a collective experience to mean that we're meeting the needs of a much wider demographic of persons? And for me, leading the charge of what the future looks like from a positive perspective is, it's not just the distribution of education to mean that people are more informed. It's also the provision of tools to mean that they can act on those, on that information and that education. And the development of systems that are providing, low cost, affordable health outputs for people that they're able to seek. Because I think what we run the risk of is that we have a modeling right now of education that's moving at light speed, but we don't have the systems that are catching up. So I think the future looks bright if we're able to embrace innovation and really fund innovation that provides those, even, it doesn't even have to be high tech, but even the low tech, but, mass scale opportunity to support people on the basic outcomes that can improve their longevity and wellness.
Yeah. So talking about the future, maybe I like to do this kind of like a little bit like thought experiments. Like, imagine the world in 2035. Like, what could that look like? And maybe we can use like the women's health example from Hormonally. Like, what could good look like there if technology is kind of doing its job and the conversations change and people are kind of using the tools? How might that look?
I personally was so excited to hear about the possibility of, more funding in these sort of women's health hubs, which were sort of centralized areas for care to take place. So for me, good looks like a move away from siloed areas of health into more holistic spaces for people to have these conversations. So I think for me, it would be looking towards systems in which we're building in options for nonprofits to work with clinicians, to work with community spaces. So really thinking about that care as a form of treatment, the experience of the patient journey from beginning to end being so much more than just a sort of clinical intervention. So also including all of those other aspects that we see in the work that we do at Hormonally, because health isn't just medication. Health is also what we're doing. It's relating, it's communication, it's building support systems. So I think for me, good looks like this sort of decentralizing on pathways and moving towards a holistic model in which we have different actors playing different roles in supporting the healthcare journey, and that accessible space being open to a wider demographic and community of people.
And from maybe an individual woman's perspective, but let me play something to you, and
Sure.
you can tell me what you think. So or I can be a man, I suppose. So, maybe I have a tool in my hand, an AI advisor that's somewhat always in touch with me, my mood, what I'm feeling, and can highlight when perhaps there's an issue. That can be kind of proactive. It's aware of all my conditions, not just the one for my brain or the one for my leg or the one for my knee or whatever.
Yeah.
It's much more kind of holistic like that. With that, I can kind of make the right actions on a day-to-day basis. Maybe I drink alcohol or I don't drink alcohol, or I go for a run, don't go for a run, or I'm eating fruit, I'm changing my diet. And through a healthier lifestyle enabled by technology, I'm living a kind of a better life and probably less of a burden on the health system. When I do have to interact with the health system, I can be kind of informed in that interaction. Maybe I use some kind of telehealth. I have a virtual call with a physician. I don't have to go to this kind of awkward place and have that awkward conversation. We have that kind of interaction. They can see the data. They can point out that actually maybe it's something a little bit more serious and you need to go for your next check. On a kind of a macro and kind of societal level, this data is kind of aggregated and we start to understand where the real issues are with health and with diseases. And those are the things where we start to invest research in. And because we can have this kind of feedback loop and we can track, we can see which of those investigations are impactful and which ones are not, and ensure that we put the right resources where we're going to have the biggest impact. I guess what that would also mean is culturally is I can talk about these things with my friends, with my family. We're not so stigmatized. Like if I've got something that today is considered weird with me, I can kind of talk about that and I can be open about that, and then get that treated and get that solved. Is that utopian future?
I love
is it a real
that.
thing?
Yes, I was like, yes,
Well,
all of these things.
I think technology can enable it. I guess the challenge is that we need to make it happen. And we have to, I guess it's available. The technology, I don't think it's the challenge. This is almost going full circle, right? It's like, do we focus the technology on this problem? And I suppose that's really like the main question.
I think there needs to be a willingness on the system level to lean into where it is that, I say this often, which is people, let's say people, not even women, but people are demonstrating where they feel safe learning about their health. And where they feel safe learning about their health is not in a one-to-one interaction in a clinical environment. Where they feel safe learning about their health is through digital tools. And we can agree or disagree with that, say it's problematic, see the issues within it, but it doesn't change that social cultural movement. And I don't think at this stage there's anything we necessarily, you have a teenager. Whenever I spend time with young people, the interaction of like media, digital, it's the way that they communicate. There's entire shared languages now from TikTok, literally, of this ways of relating and being. And I think we can position that as problematic. And again, it's that, I think, reticence for change, but there are real opportunities to lean into it if we recognize that may take some shifting in the structural landscapes we've developed to accommodate what it is and where it is that patients feel supported and empowered to learn about their bodies. I also think that we can utilize this as a tool for productivity on a mass scale. There are many instances in which you can take out a huge amount of pressure and burden on already overstressed clinicians by digitizing these systems. There are issues around different demographics of ages for this that I think we need to address from the accessibility perspective, but it doesn't mean that it's not possible. And your utopian future, I'm like, I don't really have much to add. Maybe more Vulva Map at some point, but yeah.
Lauren, thank you so much. This has
Dom.
been a really enlightening conversation. I've really enjoyed it.
Me too. Thank you.